Good morning, everyone, and welcome back to the second day of the annual NYSCF conference. So as Susan said yesterday morning, the reason that all of us are here is for patients. We saw some very impressive and groundbreaking work yesterday that we know will have an impact on patients suffering from many of the major diseases of our time. But the reality is that not everyone is benefiting from the breakthroughs that we are discussing at this conference or that are happening throughout the field. The reality is difficult to hear. Even though the mortality rate for major diseases like heart disease, stroke, and cancer has decreased thanks to these types of breakthroughs that everybody is making, the gap between Black and white mortality rates has actually increased. All of the diseases that we work on here at NYSCF, and probably what all of you work on too, have disproportionate impacts on ethnic minorities. For example, a Black woman is 22% more likely to die from heart disease than a white woman, and 71% more likely to die of cervical cancer. This extends to medical interventions too. For example, 67% of Puerto Rican children do not respond to the drugs used in asthma inhalers. All of this is, of course, being exacerbated by the pandemic, as we see every day. And perhaps one of the most striking statistics is that if they had died of COVID-19, if minorities had died of the COVID-19 at the same actual rate as white Americans, more than 20,000 Black people, 11,000 Latino people, 700 Indigenous people would still be alive today. This is a truly unacceptable loss of life. And the reality behind all of these numbers is the racial injustice that persists in our society, which the events of 2020 have brought us into a long overdue fight against. And that fight includes the work that we do as researchers. There are many reasons for these numbers, but one that we're positioned to tackle as a community is the poor representation of ethnic minorities in research and clinical trials. For example, 78% of people in genetic studies of disease up till 2018 were of European descent. A lot of the studies that we do in our community on stem cell research, on disease research, are based on stem cell lines from white males. When it comes to COVID, for example, less than 5% of NIH-funded respiratory research has reported inclusion of racial and ethnic minorities as of a few years ago, which doesn't exactly position us well. 42% of the US population as of 2019 identifies as being a minority or being of two or more ethnicities. So this is not a small number of people that we're talking about. So the impetus is on all of us to make sure that when we make discoveries and breakthroughs, that they apply to everyone who needs them. Not just the people who happen to sign up for these studies or people who have gotten their genomes sequenced, but that all communities, especially the ethnic minorities who disproportionately suffer and die from these diseases, are served by the research that we do. So it is my honor and privilege today to be moderating a panel discussion on this important topic of how we can all work together to overcome racial disparities. And this is a goal that's something near and dear to NYSCF's mission and heart. We are incredibly lucky this morning to have a panel of esteemed experts, implementers, and genuine thought leaders on this topic who represent different parts of the research ecosystem. We've been faced with the deadly consequences of systemic racism in many ways this year, and that is not something that we are going to solve today. But our goal today is to start this discourse with this community about how we can make sure that these injustices stop affecting our research so that we can all protect the lives that science is meant to serve. So I'd like to start by discussing how each of our panelists are taking on this important issue in their respective institutions. And I would invite first Dr. Monica Webb-Hooper, who's Deputy Director of the National Institute of Minority Health and Health Disparities at the National Institutes of Health, which is, of course, the largest government funding body of research, and their mission is to lead scientific research to improve minority health and reduce health disparities. So very, very appropriate for what we're talking about today. And thank you so much, Monica, for being here with us this morning.
Thank you. So I'd like to start by thanking NYSCF and the conference organizers for hosting this really important conversation and for inviting me to participate. I'm delighted to be here this morning and with all the esteemed co-panelists. So at the National Institute on Minority Health and Health Disparities, this is our mission. It's to lead scientific research across all of the National Institutes of Health to improve minority health and reduce health disparities. We envision an America in which all populations will have an equal opportunity to live long, healthy, and productive lives. And we know that in the United States, disparities in health for many illnesses have existed for centuries. We've been tracking them for about the past 35 years. And unfortunately, they persist into 2020, as you've mentioned, despite many calls for change. We do have robust evidence of disparities by race, ethnicity, and income for conditions such as cardiovascular disease, cancer, end-stage renal disease, and many others. And to accomplish our mission, NIMHD raises national awareness about the prevalence and impact of health disparities. We disseminate effective individual, community, and population level interventions to reduce and encourage elimination of disparities. So we are the youngest. We're of one of the 27 NIH Institute, and we really are interested in supporting cross-cutting, cutting-edge research that advances the science in this area using multiple approaches. We also want to ensure that medical and technical advances reach populations and communities with high needs. We focus on standardizing the methods of assessment and measuring healthcare and outcomes. And of course, developing and implementing interventions to address health disparities. We also invest in training in the next generation of scientists who are focused on these issues and have the potential to turn the dial towards health equity. We have multiple funding mechanisms that we support both within NIMHD and that we sign on for that other institutes are leading. And some of the dedicated funding mechanisms that we have currently, and this is just a small sampling, include health services research on minority health and health disparities, ethical, legal, and social implications research, long-term effects of disasters on healthcare systems serving health disparity populations, mechanisms and consequences of sleep disparities in the United States, mechanisms of disparities in chronic liver disease and cancer, social epigenomics research focused on minority health and health disparities. We have mechanisms focused on disparities in the etiology and outcomes of lung cancer in the United States. I mean, I could continue, but I'll stop there. And I'll just finally offer that the research that we support to reduce health disparities and improve minority health is across all diseases, conditions, and disorders. And as a result, all the institutes and centers at NIH are contributing to this science and supporting activities. And given the recent events at NIH, there's even a greater focus than ever before on supporting health disparity science. So I think it's an important window of opportunity that we all have to really focus on health equity. Thank you.
Thank you, Monica. I think those are really excellent points and address a lot of the questions that I think we have as we start to consider how we can do this better in our research. And I wonder if you could also talk just a little bit more about how you work with the other NIH institutes to make sure that these strategic priorities that you've outlined are recognized and reflected in RFAs or reflected in study sections. At what point does that happen?
So that's a great question, and it happens throughout the process. NIMHD is charged with coordinating these activities across NIH. We bring our mission and our vision at every possible opportunity. And I think since our new director, Eliseo Perez-Estable, took the helm in 2005, we've seen NIMHD really increase its emphasis on clinical trials, on our R01 mechanisms, which for years weren't a part of the goals of NIMHD. It was mostly focused on training, capacity building, which are also very important, and we maintain those programs as well. But we've really increased the emphasis on the R01 mechanism and other funding opportunities such as our centers of excellence. We must collaborate. Our institute is relatively small compared to the others, and so our goal is to collaborate across the institutes. We have much more involvement on working groups across NIH and across the Department of Health and Human Services to bring our mission. So this is an institute and an area, because it's not a substantive area, it's not focused on one disease. We're focused on addressing issues that relate to almost all diseases. And we certainly think about minority health and health disparities as two separate scientific domains. And we focus on both of those domains in our efforts. So I've been really pleased at the new NIH strategic plan, which has a much more significant focus on minority health and health disparities research. And then we have a strategic plan to implement within NIMHD. And that plan was informed through a long-term science visioning process, which brought together multiple stakeholders, including the affected communities, to help us think through what the work should be focused on and how we can actually move the needle.
That's excellent. And I hope this increased focus means some increased funding for your institute in the years to come.
That'd be great.
And we'll come back to that idea of collaboration shortly. But I'd like to bring on our next panelist now, Dr. Valerie Montgomery Rice, who is the first woman to lead Morehouse School of Medicine as the president and dean, which is a leading educator of personal primary care physicians located in Atlanta. And Valerie Rice also has a wonderful perspective as a physician, as an advocate, and someone who really places a huge emphasis on improving health equity by translating discovery into health equity. Valerie, I'd love welcome, and we're so delighted to have you. I was wondering if you could start by telling us a little bit more about the TXTM philosophy that's described on the Morehouse website and how you're using that to foster the health of diverse communities.
Thank you all for having me. So, we came up with this concept of TX early on when everybody was talking about translational research, right? We have always focused on health equity. Our vision is leading the creation and advancement of health equity. And then we started to say, well, what does health equity really mean? Health equity really means giving people what they need when they need it to reach their optimal level of health. But how do we know that these interventions and discoveries that we are developing are really delivering the promise of science to people? And so we came up with this concept of TX. Now, of course, T represents the research continuum. So we think about basic science research. T0, we think about increasing our fundamental knowledge on the nature of living things, and which informs our clinical research, our trial work. And we think about T1 is translation, right? And then T2 is translation into the application of research findings. And then that T3 research is associated with, but clearly not limited to, how we adopt these interventions. Well, we thought, you think about these interventions going into primary care, you think about these interventions going into a community. We say, okay, well, who actually measures the impact that those interventions have had in the community? Do they lead to the desired outcomes? Do you really see that exponential impact? And do you see the return on your investment? And so we copyrighted this TX. And it is really about, how do you translate scientific discovery into something that is meaningful and impactful? And can you measure that? So that's what TX means to us.
Thank you for describing that. You co-authored an opinion piece in the New York Times in September regarding COVID vaccine trials. And in that, you said, "We find ourselves here at another inflection point where the status quo cannot stand." Can you talk about that?
So when you think about the historical perspective, and you gave a lot of great statistics early on about disparities, right? And we all know these disparities. And I always say to people, we don't actually need another study to catalog the difference. We need studies that focus on how the interventions make a difference. And so when we look at this pandemic has disproportionately impacted people of color. When you talked about the lives saved that could have been saved, 20,000, 11,700, in the category of Black, Latinx, indigenous populations. The question now becomes, will we ensure that the therapies that we are developing, will they be disproportionately provided to those communities that are in need? Now, as it relates to the vaccine trial, though, if you have a disease that disproportionately impacts one community, we definitely need those persons to participate in the research. And the reason that I say to people that that's so important is because we believe it's at a level 3, right? We call level 3. We're at a phase 3 clinical trial. So it's already the vaccines have been tested for dosing. They've been tested for safety. But we know that there can be unexpected side effects that occur in populations of people based on the fact of what they bring to the table. Let's take, for example, people with sickle cell trait. Let's take, for example, people with chronic kidney disease. Let's take, for example, people with diabetes. We know that this virus impacts the vasculature. And all of those diseases that I talked about there, right, impact the vasculature. And we know we see a disproportionate higher number of people of color with those diseases.
Yeah.
So if we're going to give a vaccine that prevents a virus that attacks the vasculature, we want to make sure that there are no unexpected side effects. And the best way to know that is in a clinical trial. So we're at this inflection point where we now have scientists at the table who are scientists of color who are participating in the research. We have scientists at the table who are at the FDA. We have scientists at the table who are at the NIH who are saying, right, I'm here, I'm in the room where decisions are being made, and I want to be inclusive, and I want to make sure that all populations are impacted equally, or more so than if they are disproportionately impacted by the disease. So that's the inflection point. We can be empowered to make a difference, and we can be empowered to see change occur, particularly if we participate.
Thank you for those excellent points. And I will come back to the pandemic shortly. Right now, I'd like to bring on our third panelist, Dr. John Greally. And John is a professor of genetic medicine, pediatrics at Albert Einstein College of Medicine. He's also the director of the Center for Epigenomics. He's a clinician and active clinician and a clinical geneticist at Montefiore Medical Center, which is one of the top hospitals nationally, a leader in LGBTQ care, and serving Bronx as one of the most diverse counties in America. So John, thank you so much for being here with us this morning. As a researcher, geneticist, stem cell biologist, and clinician, with these different hats, can you talk about how you're taking on health disparities in your research? What types of disparities are you encountering and feel that you have the best opportunity to tackle in your research?
Raeka, thank you to you and the NYSCF for the invitation to speak today, and I'm particularly gratified by being in the presence of the co-panelists from whom I'm going to be learning a lot today. I wear a number of hats, as you say, and my motivation at the end of the day is to try to understand how to tackle human disease through the mechanism of genomics research, and that is fundamentally what has driven me from day one. My clinical service in the most diverse county in the United States, where about 10% of people are non-Hispanic white and everybody else is of different origins, has every week when I go to clinic, it points out to me not only the vast diversity that is the challenge and the strength of what we can do in New York City. It also exposes me to the socioeconomic challenges that people face, because a lot of the tensions that they bring with them to clinic have to do with the fact that they have economic and other instabilities. And by the time they come to my clinic and they have a child with autism or intellectual disability, whatever, the stakes are much higher for people who are already limited in terms of their ability to cope. So to get to the flashpoint which has made me question where the value of just going in with enthusiasm to do genomic studies, which is what drives me as a scientist. The counterbalance to all of this has been what we've experienced with the COVID-19 pandemic. 1 in every 350 people in the Bronx has died of COVID-19. It is the highest death rate of all of the boroughs in New York City, and we're not sure why. We do know that there are, and the overwhelming issues are, as Dr. Rice was saying, and as you introduced, that there are socioeconomic issues, there are health disparity issues, and there's fundamental racism that has led to where we are today as regards people of color being able to access care effectively. And we hear stories of families not seeking care because they were afraid that ICE would pick them up on the way to the hospital, which is undoubtedly contributing to some of the mortality figures that we're seeing in the Bronx. So when I was presenting to the New York-wide COVID consortium about the unusually high rate of COVID-19 mortality in the Bronx, that led to a lot of interest from commercial and academic potential partners that's to ask us, shouldn't we be sequencing your patients because they're diverse and they're dying at a higher rate? So therefore, there must be something that we can find there that would help explain it. So I had these discussions with my colleagues at Montefiore Hospital, and my colleagues at Montefiore could be working in much more glamorous circumstances. They are wonderful clinicians who are dedicated to this community that we serve. And their initial response was, we do not want to have genetics as the highlight when we know that the health disparities and racism issues are so much more to the forefront. And in fact, if we start to focus on genetics, we're not only distracting from that issue of health disparities, we're feeding the racist trolls, because we could be feeding into the argument that says that people are dying because they are genetically inferior in some way. So I'm presenting the counter argument to what I actually try to do every day, which is to understand human disease through genetics. And I can present some vignettes where the inclusion of minority populations is not only helpful in terms of understanding disease in general, it's also helpful in terms of understanding these populations that we serve, which is very much along the lines of what Dr. Hooper's vision is. And I can give a more positive viewpoint, but this is the reason why I'm particularly conflicted about what we are doing in the field of genetics, because science is much more connected to politics than we had perhaps initially thought when we entered this field as a profession.
Absolutely. Well, thank you for those important points, and we will come back to some obstacles and hopefully some positive vignettes towards the end, John. So, and I want to now bring on our fourth panelist, Susan Solomon, our CEO and founder. Susan, as our CEO and founder, and as an experienced patient advocate, can you talk about how this fight fits into your vision for NYSCF, and how NYSCF stem cell technologies and were developed, and sort of their applicability to this issue?
Thanks, Raeka, and thank you so much to all of my fellow panelists for joining us today, and also for the critical role that each of you have in the overall ecosystem, and are playing in raising awareness, and trying to thwart and really tackle these inequities that have become systemic, endemic in so many areas, and as we'll discuss specifically in identifying how we can thwart the disparities in biomedical research and clinical trials. And I do appreciate both the emphasis that we've heard so far about the really stark disparities that COVID-19 has highlighted, and also the concern that we're dealing with very large political socioeconomic issues. from a NYSCF perspective, from our initial formation of the NYSCF Research Institute, we always felt that it was essential to represent all ethnicities, genders, ages. We felt that was fundamental to the human research that we are doing. We are a diverse family, and we thought that one of the really great privileges that we have of being located in New York is that New York City is so incredibly diverse, which is really fantastic, and not at all to in any way minimize the socioeconomic and political factors, which are enormous. There is something going on. There is something going on in populations that as Valerie mentioned, are not, when you've got kids not responding to particular medications, when you've got populations of Black Americans who are just being taken out by this disease in a way that is just simply not happening otherwise. Now, some of that may well be because of the limitations of housing and so forth, but there is also something else going on, and it is not it's not a bad thing that we're different. We just have to understand what the differences are, and so we felt that human iPS cells, stem cells, offered us this unprecedented window to basically create, if you will, panels of all of us, so that not only at the moment of selecting people to participate or encouraging people or enticing people, to participate in clinical trials, but actually what it is that those trials are trialing, if you will. So the very, very basic discovery from creating the assays that are being developed, the drugs that are developed based on those assays, that you don't want to do that based solely on a population of white males. You can't do that and fairly address the issues. And from an economic perspective, you're not going to have a successful drug, because in many cases, because of the disproportionate disease burden of people of color, you're going to end up developing a drug that fails, or worst case, harm someone. So I think one of the things that we saw in 2008, when we came up with the idea of creating this the NYSCF Global Stem Cell Array, which is this stem cell technology that can create huge numbers of stem cells using robotic technology and now machine learning. And we can do that from vast numbers of people in the population. And the idea then, and we have grown that, and the technology is perfected, so we're now ready to just do way more collecting within the community, is so that we could basically take the we can't get to those people, or it's not possible, or it's too hard. We wanted to take that off the table and say, here are the diverse population, as much as we can collect of the world, certainly the United States, and please represent that in your basic research when you go to develop your drugs. And we do that ourselves, and we can do that with our partners, and that's why we built a biobank. And I think to fully recognize the potential of what stem cell research can do requires that we continue to put a lot of resource into what we refer to as the NYSCF Ethnic Diversity Biobank. We want to enable and remove any excuses for researchers around the world on the drivers of disease that are either specific to certain ethnicities, or because of the genetic or biological makeup of those ethnicities, prevent response to drugs that are being developed. So over the next couple of years, we're planning to recruit and collect several thousand additionally diverse patient samples. And we bring families into the process, because one of the things that I hope that we're going to be talking about as a panel is really the issue of trust. And I think I was very pleased to see that one of the vaccine companies, as was referred to in our alumni panel on COVID last night, Moderna has actually slowed the recruitment of patient volunteers when they realized that they didn't have the diversity that they needed to have, that they must have in order to be successful in introducing the vaccine into the community. So I think when you have a community, particularly of Black Americans, who have absolutely valid reasons not to trust the medical establishment for various trials, it is absolutely critical that those folks be at the table when the decisions are being made.
Yeah, excellent points. Thank you, Susan. I'd like to invite all of our panelists to now turn on their cameras and microphones, because I wanted to jump into that idea of the obstacles. Susan brought up a really important one, which is trust. But could each of you speak to some of the obstacles that you're facing in these really excellent efforts that you're putting forward? And John, you also mentioned, some of the dangers of research on genetic susceptibility as well. So.
Sure, I can start. I think I'm thinking about Dr. Montgomery Rice and her comments about equity. I think that, equity is, as she mentioned, the attainment of the highest level of health for all people. And it sounds like a simple concept, but achieving it's actually quite a challenge. It requires a shift, a major shift, or even a dismantling of the way systems have been set up. It requires that we value everyone equally. We focus on ongoing societal efforts, and we want to address any inequality that is avoidable, which would be inequities. We have to factor in historical and contemporary injustices. And operationally, what that looks like is something that you don't usually see. It's about distributing resources that are proportional to the need. It means going out of our way to level the playing field. And this isn't always easy due to the way that systems, institutions, and infrastructures are set up and have operated for centuries. Access to care is probably the most significant barrier to equitable health outcomes, specifically access to high quality care. It's not just being able to get into go see a hospital, go to see a doctor at a hospital. It's access to quality care, which we know that racial ethnic minority populations, particularly African Americans, have a long history and current barriers to receiving high quality care that offers state of the science medicine by the best medical providers and specialists who will not be biased against them. And that's just a reality of the conversation. I think that, the physical conditions of the medical settings are a key social determinant of health. We think about the many factors that impede or limit access to high quality care. We often talk about cost or affordability, adequate insurance coverage for most services and treatments, distance to healthcare facilities that offer the best care or emergency services. And we have to also consider diversity within the healthcare system. And while I can appreciate the idea that there's something going on, I would fully argue that what we're seeing with COVID-19 is not a genetic or biological issue. It is a structural issue. To have not only African Americans, but essentially all racial ethnic minority groups, even, other groups that we don't often talk about because of small samples, such as Native Hawaiians and Pacific Islanders, who have a disproportionate burden. Of course, American Indians, who have a disproportionate burden. So we have to really look and say this is not something that's biological. This is clearly an issue of structural inequity. And I think that's partly why it has received the attention that it has, because many basic scientists and other clinical scientists are actually understanding, in some cases for the first time, that we have to understand the full context of systemic factors. And we have to consider the impact that has on the body. And only with that deeper level of analysis will we actually utilize this critical window of opportunity that we have in front of us to address the primary causes of health disparities. And without that context, we may fail to realize the breadth of factors that are outside of the body that drive disparities and preclude ourselves from learning from our past mistakes. And that could lead to the introduction of ineffective or even harmful medical or policy solutions.
Thank you so much. These are really excellent points. Valerie, I think you were about to say something as well.
Oh, I think
We can't hear you.
Okay. Yeah. So Monica said some of the things that I definitely would have said, and she said them very eloquently. And I would just remind us to let history be our guide in some ways. And I am always reminded of two examples, and I'll just talk about one. When we came up with the wonderful antiviral therapies for HIV. So I was in medicals. I had just started residency when HIV hit, and we did not really know what the disease really was, right? And we were all terrified. And there was not this understanding of PPE and all of that. So lots of people, we lived through some terror. But as I went on in my research career as a clinician scientist, I started to look at disparities. And one of the early things that we started to see was when antiretroviral drugs came about, there was then that already disparity between Blacks and white in mortality, right, from HIV. But people were more so viewing it as a gay white male disease, okay? And when we looked at who had access to those antiretroviral drugs first, right? We did not have a policy that ensured that the people that were more disproportionately impacted would get access to those drugs. And so if you look over the curves, you saw a widening of the mortality. You saw a widening of mortality. That's what we're talking about when we talk about the structural barriers. First of all, you got to acknowledge that it exists. And then when you see the difference, what you then must do is proceed with allocating resources, and then policy sort of submits the opportunity. I think I have a fire alarm going off. Yeah. I actually have to step out for a moment too. I'm sorry.
Okay, all right. We'll come back to you.
As the president and CEO, you have to follow the rules. So I'm sorry, I got to step out.
All right, no problem. Real life. John, I think you were you about to say something earlier as well? Would you like to elaborate on your point about the genetics issue?
Oh, well, I'm actually happy.
Yeah.
I'm happy to sit here and listen to all of this other stuff, but it's really educational. But
yeah, absolutely.
I think, I don't want to, like Dr. Webb Hooper's mission is to make sure that we do study minority populations to see what we can learn from them. And I was negative in my first portrayal, but I think it needs to be balanced with the positive lessons that we can get from some of these studies. I'm not a population geneticist, but I'm a consumer of population genetics. And one of the things that population genetics has taught us is that when you include diverse people in your study, you can end up with outcomes which are better in terms of revealing mechanisms of disease and the particular susceptibilities of people of certain ancestries that you wouldn't have otherwise. And the example I always tell students about is the Dallas Heart Study, work by Helen Hobbs, where they were looking to see what were the genetic predisposing factors for fatty liver disease, which is now becoming the number one reason for people having liver failure and transplantation, because of the fact that we're also treating hepatitis, viral hepatitis, much more effectively. And in her study, about 15% of the participants were Hispanic American. Now, I'm guessing in Dallas, probably Mexican American, given that Hispanic is a very broad category. Of all of the individuals who had a particular mutation in the gene called PNPLA3, which was the big driver that they found for fatty liver disease, 2/3 of the people who were homozygous for having this mutation were in that Hispanic American group. So if they hadn't included those individuals, my guess is that they wouldn't have had the power to detect that this was actually driving a significant risk of fatty liver disease. So the value of that obviously is that you uncover something about the biology of the disease, which is great, but you also have an allele frequency for this particular mutation, which is like double in Hispanic Americans than it is in Black or white Americans, so that you're able to tailor the prediction of bad outcomes in groups where you're able to help them actively by understanding that they're at greater risk. And so that's a positive benefit. The other vignette, if I have time to talk about it, it's a kid who came to my clinic, and he had a malformation of his foot. His hips, he was a toddler, his hips were clicking out of their sockets. When I looked at his chest, it was asymmetrical, and it was as if the left side of his head was pushed forward relative to the right. So he had evidence for a skeletal dysplasia, an abnormality of the formation of the bones of the body. So the mother was Central American and Puerto Rican in ancestry. The father was Puerto Rican. And for some reason, I ordered a test which was looking for a mutation associated with short stature, which this child didn't have, and skeletal problems that's very much enriched in the Puerto Rican population. So it came back positive. And this is an interesting mutation. It's studied by my colleague at Mount Sinai, Emer Kenny. And if you look at the DNA around this particular mutation on a gene called Tol27A1, a collagen gene, the DNA flanking it is clearly from the indigenous people of the Caribbean, the Taino Indians. So it's a reflection of the history of Puerto Rico, an island population where these kinds of alleles of genes that are not particularly advantageous are able to propagate themselves. And as an Irish person, where we also have a kind of a sort of a cloistered or somewhat inbred population, we have other things. I'm a carrier for hemochromatosis. So we understand that there are certain alleles that are rare worldwide, but in the population you serve may be common. And in the Bronx, we have a lot of Puerto Ricans, so therefore this particular mutation is common. But the other thing that's really important is that if you have this particular mutation and you try doing surgery on this little boy's hips, the outcomes are dismal. So this is an example of, it's not an academic exercise saying, I happen to know why your child has this hip problem, this skeletal dysplasia. It's also adjusting the way you should be treating those children compared with the 99 other kids who come into your clinic who have hip dysplasia, who would be treated in the mainstream ways. It's a way of tailoring treatment to people in a way that is that reflects the fact that you understand the community that you serve, and you can treat them better as a consequence. So that's the upbeat counterpoint.
That is upbeat, and that is what we want precision medicine to be able to do, is actually, be able to recognize some of those opportunities to do better when it comes to treatment.
What I hear, Monica, what you're emphasizing is that because we clearly don't have a clinically level playing field, and because of the systemic problems that have persisted for forever, we don't have the level of care for Black and other minority populations that we do, for the majority population. Until that is addressed, it's going to be very difficult on a clinical basis to not be distracted, if you will, by genetic underpinnings. I think we have to really attack all of it. I mean, because the world is so politicized, I think there's a risk, and I think, John, you mentioned it in some pre-remarks, of saying, oh, well, this is a biological thing, when in fact this is an inadequate resource thing. And if people had access to the best care and the proper care, that the outcomes would be substantially improved. And I think that that's also really clear. I think they all exist. And I think that we all have to kind of do as much as we can to make sure that we're addressing both the systemic care issues. What I'm really concerned about, and I hope that Valerie is able to come back and join us, but is the pipeline issue too, because I think that's something we spend time on, and I think is really important, so that we have more people in the room. You want to have, when we created our gender program, one of the
oh, good, you're back.
Welcome back.
Welcome back.
I'm outside.
Okay, good.
You really are having a fire alarm.
Locations, perfect. Why not? COVID, a fire alarm.
It's a beautiful setting. It's great.
Yeah, you look great. You look great.
Wait, what happened? Sorry, I missed all the great conversation.
No problem.
But you mentioned leadership and making sure, you both did that. Monica, when you talked about being ubiquitous, being when Raeka asked, is your institute, how do you play with all the other institutes? And you're like, we're in their face all the time, just saying this is important. And Valerie, you talked about being at the table. And one of the things that we did with when we started in 2014 a gender initiative, which is helped a little, is to make sure that when the decisions are being made of the power decisions, whether it's the give out the money decisions or who gets the big appointments decisions or the tenure decisions, anything that's a kind of a power decision, that you have people in the room who look like the people whose interests need to be reflected, because otherwise you don't get the same result, whether you call it unconscious bias or you call it whatever you call it. It's just not going to happen.
Right. One of the things that, and you all may have covered this, so please forgive me. I think it's so important that we address the pipeline, right? And I think you may have been alluding to that. And this pipeline is so important about who we educate and train. And John, thank you for your comments, and thank you for the struggle that you're going through and the pushback you're giving people about, okay, is this really genetics? You're a geneticist, so you're saying, is this really genetics? And I don't want to dilute the conversation, and I don't want to absorb anybody of their responsibility. And so when you have diverse persons in the room, or when you people culturally competent, meaning that they're able to really participate in understanding other people's circumstances, even if they have not lived them, because they have made themselves aware, that is when we get the rich solutions. That is when we get the solutions that are going to be inclusive of others. When you think about our classrooms, we learn more easily when we can relate to an experience. And if we have a trusting relationship with one of our fellow colleagues as a student, etc., we begin to have a different perspective when we hear about disparities, when we hear about inequities. And therefore, we also work harder to find solutions. And so it is about being connected. And I think that one of the things that we must do is ensure that we have diversity at the table. Diversity by gender, race, and ethnicity, but also diversity of thought. That is also equally important, because that's how we get to these great solutions. So I just thank you, Susan, for recognizing that, yes, we want to know what's happening at the genome level. And I thank you, Monica, for pointing out that we got to remove these structural and systemic barriers. And then John, recognizing that these are hard conversations, because it would be easy, you all, to say, you know what, the Black and brown people are disproportionately impacted by this disease because of some genetic defect. Therefore, that would change the whole conversation. We know that that's not the case. We know that if we solved for the structural, systemic, racial barriers that have been put in place, if we address the social determinants, if we provided an opportunity for people to actually receive testing when they ask for it or on a periodic basis, we know that if everybody had the opportunity to be tested within 24 hours, and within 24 hours we were receiving monoclonal antibodies and remdesivir and steroids, all of us could receive that in 24 hours. Guess what would happen? We would have saved all of those lives. There would be people, we wouldn't have to see CNN every hour, at the end of every hour, highlight someone who has lost someone. These are the things that we actually can control, and it doesn't take a scientific genius to figure this out. It just takes caring.
And leadership.
She gives me the chills. She gives me the chills. I'm so with you. That was awesome.
That was beautiful. I mean, I think that sets up, a point that I wanted to cover, which is that this is obviously so complex. There are so many, contributors to these disparities, and we need to be aware of all of those. And so that's part of why we brought, diversity of thought onto this panel and diversity of roles onto this panel. And so I'd like to hear from each of you how you think everyone here can sort of work together from these different parts of the ecosystem as stakeholders in this to achieve what we can achieve on our own. Researchers, we obviously need to be aware of what's of the structural issues. And as Valerie, I know that Morehouse just received a $40 million grant from HHS, so that's an example of a partnership with government to be able to address the disparities in Black populations with COVID. So, what are some of those opportunities do you think that we need to be working together more on?
I think having different partnerships and unique partnerships, and not the norm partnerships, right? And I think COVID has allowed for that to be the case. So the grant that we got, the $40 million grant from HHS, is a cooperative agreement that is really called the COVID-19 Resiliency Network. And it is partnered, though, with 40 community-based organizations throughout this country, looking at 5 vulnerable populations, and you can imagine who those are. But we are going to those grassroots organizations and saying, how do we build the right culturally competent, linguistically appropriate educational tools that really answer the questions in the way that people are asking the questions so that they build that trust. We want to direct people to resources, and we want to answer people's hard questions about genomics and vaccines and therapeutics. And when we don't know, we say we don't know the answer, but let's try to come up with a strategy to figure it out together. So that grant has been really, really important for helping us to build a network so that people will know resources. And you all, this is going to be critically important for the vaccine. There are 2 ways you can measure the effectiveness of a vaccine, right? One is that you give the injection to someone and it produces the antibodies, and hey, they may be immune for a period of time. But the other measure of effectiveness is what is going to be the uptake of those persons who are at greatest risk of the disease. And if we do not do that second one, we will just have a really pretty nice vaccine that sits on the shelf, but we would not have eliminated the risk associated with this disease. And so we got to spend a lot of effort in ensuring that we are making the public comfortable, and we have to meet them where they are. They are not going to come to our nice, shiny buildings. We have to be in mobile vans. We have to go to the community centers. We have to partner with FQHCs. We have to step out of our comfort zones to meet people where they are. And we have to make sure that financially, that is not a barrier. I believe that the vaccine should be free to everyone. Okay? I think you have to remove the financial barrier.
Yeah. Monica, would you like to add to that?
That was very, very well said. The only thing I would say also is that, the session title here about developing new models of biomedical research to overcome racial health disparities, I think that it has to be an all hands effort. We must have stakeholders at all levels, all disciplines, across organizations that they all will be needed to get this work done. I think that all too often, grassroots organizations who are on the ground doing this work daily and have keen insights into community needs are often not included, or if they are included, they're not equitably included in these partnerships. So equitable engagement with affected communities is a cornerstone of community engaged work and efforts that will address disparities and move us towards justice. Otherwise, you often have studies that have too few, as we've noted, racially and ethnically diverse patients, or community members in their development. It affects implementation. And as a result, you have these sort of acontextually developed interventions that may largely benefit health outcomes in one sector of society, while inadvertently creating, maintaining, or increasing health disparities in another. And at NIH right now, we have several initiatives that are ongoing, such as our Rapid Acceleration of Diagnostics Underserved Populations Initiative, which is focused on testing and how to increase access and uptake of testing. We also have a new initiative called, the acronym is SEAL, which is Community Engagement Alliance Against COVID-19 Disparities, which is very much focused on the vaccine and on therapeutics and on trials and in facilitating diverse populations across these trials. We also, Dr. Montgomery Rice mentioned Moderna. We worked very closely with Moderna to really emphasize the importance of this. And they did come around and get on board, but I don't think that that's necessarily the way companies who are developing vaccines and therapeutics often think. And so we have a lot to add by bringing partners across the spectrum to engage in collaboration, shared decision-making, co-learning, and trust and transparency are critical elements of that.
Thank you so much. So we're just in our last few minutes here. I want to ask for sort of closing thoughts from each of you, and to sort of touch on what you think. We have an audience of researchers and clinicians from all over the world, primarily in stem cell research. What are some of the things that you think everybody watching today can think about or can do concretely to take on this critical issue and help us develop this new model that we've been discussing?
So I think that from a research perspective, I think everyone individually has to assume a leadership role in this. I think that those of us who are leading institutions, leading initiatives, leading organizations have another level of responsibility in terms of leadership. But I think everyone individually has to decide that this really matters to them, and they have to take a leadership role. Sort of think about, as we discussed yesterday morning with Tony Coles, kind of what I refer to as a deliberate approach to their entire life. And I think this means ensuring that they have representation in their samples, in their trial design. I think that's all really important. I think the pipeline issue is really critical. We began to tackle it when we had no money, no funding, no grants, because it was really important to do. And I think making sure that we highlight that. So whether it's teacher training, internships, where we start, we can only do a small amount, but we try to scale it with training teachers, reaching out to very young people, middle schoolers, to just, help them understand this is an incredibly exciting opportunity with good jobs, with an exciting life, with economic opportunity, and just draw more people in so we have a more balanced community. But I think it's will and leadership at every level.
Thank you. John? Would you like to?
Sorry, unmuting myself. Let me address all the other old white guys out there. I love pipelines, but pipelines may come to fruition in 10 years' time. What we have I am so not in any minority group. I have no insights whatsoever. But what I can do is I can promote people into positions of leadership. And if we do that and we start changing the spectrum of the faces that are visible to our communities that we're serving in terms of the research, we will not only get the diverse voices around the table which help with decision making, we'll be tuned into why, with the best will in the world, I am going to be stepping on very sensitive issues when I design these studies. So I think the confusion that I have about genomics is healthy. It's prompting me to rethink some of my basic assumptions. Go out there and read, there's a great chapter in Ibram Kendi's book, How to Be an Anti-Racist, about genomics. There's a horrendous book by Harriet Washington called Medical Apartheid, which we should all be reading. And if we learn if we learn all of these things about how our history and our current practice is not necessarily attuned to these communities that I'm trying to serve myself and others are trying to as well. And that we have the opportunity to change the landscape quickly if we choose to exercise our levers of power in a thoughtful way, then I think we can make a big difference quickly.
Thank you, John. Monica.
I know that we are at time, so I will only add that I think what something concrete researchers can do, researchers in this virtual audience, would be to really focus on the diversity and inclusion in their clinical trials. Stem cell researchers, stem cell trials are, really at a dearth of racial ethnic minority participants. It's a longstanding problem, one that does need to be addressed in phase 2 and 3 clinical trials. And I think that there's an opportunity to really go back to the trial teams to think about that, whether they are sufficiently diverse with regard to demographics at the level of the PI and the investigators, in addition to the staff who carry out the operational work. So I'd encourage them to do that and to rethink any of their sort of pre-assumptions about groups being hard to reach, which is one of my least favorite labels to give to communities. I think that racial ethnic minorities are just as willing to participate in trials. Several well-conducted studies demonstrate that. Instead, the approaches that we are taking need to be modified. The system needs to change rather than thinking that we're going to apply labels to people or try to fix them. We need to think about what the best approaches are and do the work of figuring it out, reading, consulting. I think that's what the biomedical community is, a major issue that's concrete that can be worked on.
Thank you so much, Monica. Valerie, let's give you the last word.
Thank you. And I will just say, I agree with Monica, and I'm so pleased to see what John has said about realizing how we utilize the past really to inform our future and to make different decisions. And then I want to touch on something Susan said. Stem cell research is important, you all, because it does allow for these models to be developed. Because with this virus, we know the cells that we really want to boost up are those T cells, right? We want those T killer cells or whatever they're going to do to come in there and create this long-term immunity or be this killer. And we need to know, if we got to have diverse samples that we are using to build these stem cell models to make sure that what we are expecting comes to fruition. So I don't want us to lose sight of the diversity at all level of inclusion in clinical trials, even early on when we are collecting cells to develop stem cell models. Absolutely. And then I would just end with this: stay focused. Stay focused on what the goal is. The goal is, you all, we want people to achieve health equity. And that means we have to give them what they need, when they need it, and the amount they need to reach their optimal level of health. For some people, that's transportation. For some people, that's testing. For some people, that's housing. For some people, that's a quarantine when I turn positive and I can stay off for 2 weeks and I don't lose my job.
Yeah.
And then for others, there is access to monoclonal antibodies, access to all of the latest therapies within 24 hours, right, of being diagnosed, so that you get to walk out of the hospital in 3 days and say, hey, look at me. Okay, we want everybody to be able to say, hey, look at me. Look how good I look now. And I had COVID-19.
Yeah, that is,
Yeah.
Extremely well said. You'd have a round of applause if we were in an actual auditorium right now, and I can't think of a better way to close that. So I want to thank all of you so much for starting this discourse. This is the beginning. This is not the end of our discussion. And I really encourage everybody in the audience. I appreciate the comments that have been coming in. I apologize we didn't get through many questions from the audience, but please keep this discussion going. It's so critical that we all work together on this problem. So thank you all once again. We're going to take a break now for just about 6 minutes and reconvene for our diabetes session shortly. So thank you all very much again.